I have nothing to disclose. Some brief objectives are to talk about some well-known structural GI complications of heterotaxy with a lot of focus on intestinal rotation anomalies. We'll talk briefly about biliary atresia, and then one slide on sort of what is not known about GI complications in heterotaxy. So we'll start by talking about some structural GI complications of heterotaxy. And this first group are actually anatomic abnormalities that are part of the diagnostic criteria for heterotaxy syndrome. The first group is abdominal situs abnormalities, which we can look over here in our picture. On the left side here, we have sort of normal anatomy. We have our left-sided heart with stomach and spleen also on the left, and our liver tucked up under on the right. Comparatively, if you go all the way over here, the opposite of that would be complete abdominal situs inversus, where we have our liver over on the left now, and our spleen and our stomach are on the right. In the middle of that spectrum, though, are what is known as midline or transverse liver, where you can see that the liver, instead of being just on one side, actually crosses the midline. There are two forms of that. There's right isomerism, which is more likely to be associated with asplenia, and then there is left isomerism, which is more likely to be associated with polysplenia. Other sort of anatomic anomalies that comprise diagnostic criteria include intestinal rotation anomalies that we'll talk a lot about, and absent gallbladder. Outside of those diagnostic criteria, there are many other GI structural abnormalities that are well documented in heterotaxy patients. The first two, annular pancreas and agenesis of the dorsal pancreas, have to do with embryology of how our GI tract develops when we're a fetus. Here you can see you have your intestine, which will later become your duodenum, the first part of your small intestine. And when your pancreas is forming, you have two different buds. You have a ventral bud over here and a dorsal bud over here. During normal embryology and development, your intestine rotates counterclockwise so that this ventral bud swings over and joins up with the dorsal bud over here, which ultimately becomes one singular full functioning pancreas. You can imagine if this swings clockwise instead of counterclockwise, this little dorsal bud or ventral bud, ends up sort of wrapping around the front of the duodenum, which we call an annular pancreas. If it's too tight, it can cause compression or obstruction, which is a problem. Agenesis of the dorsal pancreas essentially just means this large dorsal bud, which is the large majority of what becomes the mature pancreas, never develops. And so all somebody would have would be this tiny ventral bud, which may lead to problems with issues of the pancreas down the line. Other common anatomic abnormalities that are well documented in literature for heterotaxy patients include duodenal atresia, where part of the duodenum, which is the first part of the small intestine, does not develop. So it's atretic. You can have a pre-duodenal portal vein, which essentially means you have this portal vein, which is a large vein that usually sits behind your duodenum. But again, if it sits on top, similar to sort of an annular pancreas, it can cause compression and obstruction. Microgastria, which is a fancy word for small stomach, which you can imagine can be a problem in an infant if their stomach is too small. They can't take in enough food to grow. They might have problems with vomiting or with bad reflux. And then these two at the bottom here, in italics, anal atresia and tracheoesophageal fistula are sort of case reports of heterotaxy patients having these. Anal atresia meaning there's no exit from the GI tract through your anus. And tracheoesophageal fistula, meaning there's an abnormal connection between your trachea and your esophagus. Of course, the large lion's share of issues that come up have to do with intestinal rotation anomalies. And these next few slides are largely adapted from one of my colleagues, our surgeon, Dr. Ben Zendejas. So intestinal rotation anomalies are when there's an incomplete or non-rotation of the intestinal contents around the SMA, which is your superior mesenteric artery, during embryologic development. It's somewhat rare. It's about 4 per every 10,000 infants, more likely to be in males than females by about a 2-to-1 ratio, and most commonly identified in infants, so those less than 1 year of age. Importantly, it can be associated with other anomalies. And you'll see here, obviously, that we're talking about today, a large portion of heterotaxy patients are thought to have intestinal rotation anomalies, somewhere between 40 and 90%. I think before we talk more about this, it's really important to talk about what normal intestinal rotation in utero is like. So again, taking us back to some embryology, normally beginning around gestational week 5, the midgut, which eventually turns into your mainly your small intestine, undergoes a sequence of growth, elongation, and rotation, which yields what we end up having a normal anatomy positioning inside of our abdomen. Essentially what happens is you have a bunch of the intestines that actually come outside, meaning herniate or leave the fetus outside of the fetus so that they can grow with enough space. Ultimately, when they come back into the abdomen, these are supposed to do a few important turns. The first turn to think about is this proximal duodenal jejunal loop, and that just is the fancy words for the first part of your small intestine, is meant to rotate 270 degrees posterior and to the left. And what that ends up being is this beautiful C-sweep, we call it here, where this part of your small intestine crosses your midline. Oppositely, your cecocolic, which is basically your cecum, the first part of your large intestine and the rest of your large intestine, are meant to move anterior and to the right so that they end up, your cecum ends up down here in the right lower quadrant. What's most important is that at the end of all of this, you have this long structure called the ligament of Treitz that ends up tacking your small intestine up here in your left upper quadrant, and then your large intestine down in the right lower quadrant. And this large ligament is important because your mesentery sort of fans out from there and has a broad width in a normal person anatomy. This is a complex process, as you can imagine. So disruption at any point during that process can lead to malrotation, but every malrotation can be different. You know, there's a spectrum of things that can go wrong, which leads to a spectrum of different options. The most common intestinal malrotation refers to when the duodenal jejunal limb, which is this right here, doesn't rotate at all. It's non-rotated. So instead of having that nice C-sweep we saw before, it just goes straight down. And then you have this cecocolic, which is again the large intestine, partially rotates, but it doesn't actually come all the way down to the right lower quadrant. So instead of being down here, it's up in your mid-abdomen. And then instead of having that nice long ligament of Treitz that we saw, that nice long diagonal, you have these what are called Ladd's bands, which are essentially like strong tissue bands that attach the cecum to your abdominal wall. You can see here that it crosses over the duodenum, which can be a problem, causing obstruction, and it can also lead to something called volvulus. So the two sort of main considerations when thinking about intestinal malrotation are those two things. One, the first thing is that instead of having this nice long band ligament of Treitz where you can see the mesentery is nice and fanned out, you have a very narrow mesenteric base, which makes it very easy for this intestine to twist among itself, and that is called volvulus, which we see depicted here. The other problem to think about is that you have Ladd's bands crossing the duodenum, like we saw in the prior picture, that can lead to obstruction. So what is volvulus? Volvulus is the fancy term for intestines twisting around itself and that mesentery that supports it, which causes a bowel obstruction. The reason that this is such a hot topic is that it can lead to death or necrosis of the bowel, and in extreme cases can lead to sepsis and death. The symptoms are abdominal distension, meaning like bloating, big belly, pain, vomiting, which may or may not be bilious. Bilious emesis is shown down here in this sort of bright fluorescent green. Kids can show up as constipated and have bloody stools. The workup, super important if there's any suspicion for this, that an upper GI series should be done, which is depicted here when a patient swallows dye and we watch it. Here you can see that it fills the stomach, and then you can see this corkscrew. You can imagine that the intestines are twisted on themselves here, and then you see no further dye because it's obstructed or blocked. This then would lead to a surgical consult for emergent intervention. The intervention is called a Ladd's procedure, where the surgeons open up the belly, take a look at the bowel, they untwist it, and then hopefully there's no necrotic bowel, and they sort of tack the bowel up inside the abdomen where it's meant to stay. Just to round out our intestinal rotation anomalies, there's something called intestinal non-rotation, where essentially after the midgut comes out of the abdomen and grows, when it goes back into the abdomen, it actually doesn't rotate at all. So it's non-rotated, and you can see the small bowel just goes straight down instead of that swoop over here. And the large bowel is again sort of more in the mid-abdomen rather than the right lower quadrant. This, though, has a much lower risk of volvulus, once again, because instead of having that narrow mesenteric base, the mesentery here you can see is more fanned out like a normal looking mesentery. So why is this, what is the hot topic about this? This, because we know it is so common in heterotaxy patients, there was a period of time where patients were prophylactically screened and then actually having Ladd's procedures, again, that corrective procedure done. And then there's been a lot of research into this, those are no longer the recommendations. And here's some data as to why. So there have been a few systematic reviews done. This was looking at is screening for malrotation essentially in heterotaxy patients really necessary? This followed 414 patients who were managed expectantly, meaning they were not screened, they were just watching to see what happened to them. And of that 414, one singular patient went on to develop a symptom that was attributable to an intestinal rotation anomaly. On the other hand, there was a screening group where kids were screened just once they knew they had heterotaxy. Among that group, 53% ended up with a LADS procedure, and the overall complication rate for that was 17%, which is quite high. Additionally, the 30-day mortality rate for those kids was between 2.6 and 4.6%, very high, and all of the deaths were attributed to cardiac respiratory failure. So this review sort of suggested that asymptomatic patients are at very low risk of developing complications from an intestinal rotation problem, and that surgical intervention actually carries significant complication rates. Similarly, another systematic review about the next year was looking at observation versus prophylactic LADS procedure. And in this, there were 649 heterotaxy patients. 27% of them underwent a LADS procedure. However, of those, only 8 of them, or 1.2%, actually had a LADS procedure for volvulus. The rest were prophylactic. Again, the post-operative complication rates were high, 14% here. 10% had a small bowel obstruction, meaning they had to go back to the OR. Perioperative and overall mortality rates were quite high, 3% perioperative and 21% overall mortality rate. So again, showing that sort of high rates of complication for low risk of actually having problems. And then lastly, there's been looking into is fixing these, is undergoing a LADS procedure, putting these infants at higher risk for early shunt failure. And this followed two sort of groups of patients, 54 children who had heterotaxy syndrome and single ventricle physiology who had a LADS procedure. Again, of the 54, only 3 had symptoms, so the rest were prophylactic. 7% had to go back to the OR for a bowel obstruction, and almost 6% had in-hospital mortality. And then there was 21 children who had heterotaxy, single ventricle physiology, and a systemic pulmonary shunt who had a LADS procedure. And 20% of those had early shunt failure after their LADS, again, showing that this is like a high-risk procedure for this group. So the summary for this would be to say that malrotation is very common in heterotaxy, but symptomatic malrotation or volvulus is actually extremely rare. We think less than 5% of the time, and these studies even say around the 1% mark. These studies also showed that LADS procedure carries significant morbidity or mortality risk in this population, and so therefore prophylactic LADS procedure is not indicated, and screening asymptomatic patients is also not indicated. And so just round out this area to say sort of the clinical implications of the structural anomalies that we've talked about, including the pancreas problems, duodenum problems, the intestinal anomaly problems, is that some clinical applications, there actually may be none, right? We think up to 70 or even 90% of heterotaxy patients have malrotation and are asymptomatic. Volvulus, of course, as we talked about, is a known clinical complication. Obstruction, which we can see in the malrotation. We can also see it in things like duodenal atresia and our annular pancreas. Feeding intolerance is common, could really be a result of many of the anatomic anomalies. Atypical abdominal pain is an important thing for children and parents of kids with heterotaxy to have on their mind. This essentially means you can imagine if your appendix is in your mid-abdomen because you have malrotation and it's not in your right lower quadrant, that people may present with appendicitis having mid-abdomen pain instead of right lower quadrant pain. And so it's really important to have it on people's minds that perhaps pain would present differently than what sort of medical personnel are used to. And then there is some data, although it's a little bit murky, about increased risk of gallstones, pancreatitis, and diabetes, mainly in the children who have pancreas issues related to their heterotaxy. And so now I'm going to touch briefly on biliary atresia. I'm very fortunate in that in my institution, I have a whole liver team who I can refer patients to. And so I've borrowed some of these slides from my colleague, Dr. Wehrman. Biliary atresia is a very rare liver disease that affects infants. It's about 1 in every 8 to 15,000 infants. The cause is unknown, but it leads to sort of progressive fibrosis or scarring of the bile ducts in the first few months after birth. Like I said, etiology unknown. We don't really know. Could it be environment, the viral trigger, or some immune dysregulation? There is a surgical treatment, although it is not a cure, called a Kasai procedure, which is a hepatoportoenterostomy, essentially meaning taking out all of these dead atretic biliary ducts and then attaching the intestine directly to the liver to allow bile to drain again. Unfortunately, despite this corrective surgery, about 40% of children who have biliary atresia will need a liver transplant before the age of 2. And actually, biliary atresia is now the leading indication of pediatric liver transplants in the United States. Early surgery is really important because it's been shown to improve transplant-free survival. But unfortunately, early diagnosis is very challenging due to sort of non-specific biomarkers, lack of signs or clinical signs until very late in the disease, and then also delayed presentation to hepatology. Important to talk about this, there is an entity called biliary atresia splenic malformation syndrome. And that is that about 10 to 15% of patients who have biliary atresia have laterality defects, which would include malrotation, polysplenia, interrupted IBC. Unfortunately, these children with BASM, seem to present earlier to care, which you would think would be good because we talked about earlier is better, but have worse outcomes. Late diagnosis of biliary atresia affects long-term outcomes. Children who have a successful Kasai procedure when they're young are less likely to require liver transplant in infancy, like we talked about. And we think that the Kasai procedure is more likely to be successful the younger the infant is. For a long time, we have used 60 days, meaning the infant who has the corrective procedure before 60 days of life is more likely to have longer survival. And there's newer evidence saying that actually that number should probably be 30 days of life, so quite early on. And unfortunately, the average age at the time of Kasai in the US is more than 60 days. And this is just a picture showing essentially, like we talked about, they take part of the small intestine and attach it directly to the liver to help bile flow out. Bile, if it stays in the liver, causes scarring, ultimately cirrhosis, and then causes liver failure and can cause death. So what to do about this? There has been a large study taken place in South Texas between 2015 and 2018, where every newborn was screened within the first 60 hours of life with a heel stick for both their total and direct bilirubin. If things were normal in the first 60 hours of life, they were not followed again. If they were abnormal, they had a repeat check at their two-week well child check. And this is just a schematic of what happened. So there were 125,000 births and about 122,000 kids screened out immediately at the 60-hour of life mark, meaning that 99% of infants were negative on their first screen. Of the remaining, 1.1%, there were then almost 9% of infants who were positive at their second screen, meaning 119 patients. Of those, 7 patients end up having biliary atresia. Important to note, all patients with biliary atresia here had positive stage 1 and stage 2 results, which leads to, as you'll see, very high sensitivity, very high specificity, and very high negative predictive value, but unfortunately very low positive predictive value because you end up with 7 out of the 125,000. But we're thinking about cost-benefit analysis considering how progressive and high mortality this disease has. And so biliary atresia, just our quick conclusion on that, is that any abnormal direct bilirubin at birth or shortly after birth is abnormal and needs to be repeated and evaluated, especially in infants with heterotaxy. So that leads me to sort of our last point, which is thinking about what is not known about GI complications of heterotaxy. You've heard during this about many different anatomic things that can go awry, but we haven't talked about at all how the GI tract actually functions. Which the motility or dysmotility of the GI tract, meaning how does it move through the lung, how does it absorb? We know that there are problems with motility and dysmotility end up with feeding intolerance, constipation, abdominal pain, bloating, which many heterotaxy patients experience, at least in their infancy. But we don't know at all about how the GI tract actually works in those patients, if there's a problem outside of a structural issue or related to a structural issue. We don't know anything about patient-reported GI outcomes. Are heterotaxy patients out there having belly pain, constipation? We don't know. And what are sort of just the rates and morbidity of the GI complications that this population sees? So in conclusion, we say that structural anomalies of the GI tract are very common in heterotaxy, and some are even diagnostic criteria. Intestinal rotational issues are common, but are unlikely to cause harm and should not be screened for and should not be repaired prophylactically. Biliary atresia is rare but life-threatening, and consider early screening with total and direct bilirubin. But as we just said, much remains unknown about GI issues and heterotaxy, so hopefully more to come over the years. Thank you very much for your attention today.